Why don't we go ahead and get started? I just have a couple updates for everybody, and then we're going to get started with this panel we're very excited about. I'm Angie McGowan, for anybody that I haven't met before. I'm the director of the Alliance, and we're really happy to see you all here in February. We're really looking forward today to having a chance to focus on state efforts to build and promote public health systems and to protect public health authority and the ability to act to protect and promote health. Rya, I'm seeing, I think, the wrong screen right now. There we go. In general, you'll see that we have an amazing panel, a group of panelists today to share some of their lessons with us, and then we'll have a chance to open things up for group discussion. If you can go to the update slide, we have just a couple milestones, activities, and events that we wanted to tell you about. First, February is American Heart Month, and so just wanted to make sure that we're all focusing on empowering individuals and especially women and encourage them to learn the risks and symptoms of heart disease. We're at APHA are really excited about National Public Health Week, which is the first week in April. The theme this year hopefully will be of interest to all of you all, which is protecting, connecting, and thriving. We're all public health. We know a lot of you all do activities for National Public Health Week, so please make sure that you share your activities with us. And if you'll check out our website for National Public Health Week, which we'll put in the chat, you can add activities then, and you can also see those that are already scheduled on the agenda. And we'll talk more about this next month as we get ready for National Public Health Week. And then finally, it's time to start thinking about our American Public Health Association 2024 meeting, which will take place in Minneapolis at the end of October. Abstracts are currently open through March 29th, but we hope to see a number of you all there. So great to see you all. With that, I had a couple new people we want to welcome to our Alliance team. We have both a new spring intern, Tariq Bailey, who is a second year getting his master's in public health at the University of Maryland. And we have Abigail Otterson, who is a public health law fellow working with the CDC Change Lab Solution Program and is working with us. She just finished her master's in public health recently at Boston University, and we're glad to have her joining us too. With that, I will turn to what I know we're all excited to hear about today, which is a discussion about some of these state efforts to transform public health. But we also wanted to make sure to focus some on what we need to do to make sure we're protecting the authority to act. We have three presenters. We'll hear first from Dr. Oluwatosin Olateju, who's a commissioner and also the co-chair for the Maryland Commission on Public Health. Then Katie Greene, who's a director for public health at the National Academy for State Health Policy, will tell us some about their work looking at public health modernization at the state level and also creating linkages between public health and healthcare. And then finally, Rya, who works with us at the Alliance, will share lessons from work we're doing with partners to help protect public health authority and the ability to act to protect and promote health. After their presentations, of course, we'll turn it open to you all for questions and discuss what's happening in your area of the world. What I'll do is I'll introduce the presenters as they're kind of getting their slides and such ready, and that way we can have a transition between. So our first presenter, and I think she's going to share slides, is Tosin, and she is an assistant professor at the Helene Fold School of Nursing at Coppin State University. She's also a grassroots public health nurse leader with extensive experience working in local health departments across Maryland and serving as a bedside nurse in Maryland hospitals, specializing in neurology, neurosurgery, and psychiatric nursing. In 2019, she founded Food and Care for All, a nonprofit organization promoting food security and equitable health services for underserved populations in Maryland, the US, and Sub-Saharan Africa. She got her Bachelor's of Science in Nursing and a Master of Science in Community and Public Health Nursing from the University of Maryland, Baltimore, has a doctorate in public health from Morgan State University School of Community Health and Policy, and specialized in health policy and management. And with that, I will turn it over to you. Thank you.
Thank you so much, Angie. Please give me a minute to share my slide. For those that are on the call today, welcome, welcome. Thank you so much for joining in. Right. Okay, and give me thumbs up if you can see my slide here. Okay, awesome, fantastic. I'm going to put it on presenter view. All right. Another thumbs up. Okay, awesome. Let me go back to the beginning. So, thank you for the introduction once again. Today I'll be talking about Maryland Commission on Public Health and our efforts so far. But first I want to give a background about this commission, how it all started, where we are now, and what we hope to achieve. So, next slide here. Okay. So, in May 2023, Governor Westmore signed House Bill 214 into law. And this bill establishes the Commission on Public Health to begin its operations on June 1st, 2023, and sunset on June 30th, 2025. Now, the purpose of this commission is to assess the foundational public health capabilities of Maryland Department of Health and local departments and make recommendations for reform in specified areas. Now, I just wanted to, give an extra background information here. While the commission, of course, per law was started June 1st, but per law, we didn't really get started until November, and I'll explain that. So the co-chairs met in November, I think somewhere between second week or third week of last year. And then finally, we had a general commission meeting in December, which was virtual. Now, this was because most people did not receive their appointment letters up until like October last year. So, those were some of the delays that we had just getting started. So fast forward now where we are, we host one public meeting every month from 2 to 5 p.m. It's hybrid. And I'll discuss some challenges and successes along the way. As part of this effort, we are charged to produce two reports actually. There's the interim report, which was due December of last year. And then there's the final report, which is just, set to be due December of this year. Now, we were able to get the interim report in, but of course, given that our first meeting wasn't until until December, but we submitted it. The main highlights of the interim report were the fact that we established the work groups as stipulated by the legislation. So the legislation wanted us to establish 5 work groups: workforce, governance and organizational capabilities, funding, data and IT, right? So we did all of that. And then fast forward, we also, so once those work groups were established, we put out a call for applications for people, members of the public, to join the work groups. So right now we have over 100 members as part of the work group, which is really, really impressive. Now, the commissioners that were appointed by Governor Westmore were 16. It was 16 of us, and these people are from diverse backgrounds in public health. We have the co-chairs. Among the co-chairs, we have myself. I'm part of academic institution in Maryland here, HBCU specifically, because I teach as a full-time assistant professor of nursing at Coppin State University and an adjunct professor at Morgan State University School of Community Health and Policy. We also have Dr. Boris Lushniak, who's the Dean of University of Maryland School of Public Health. And then we have Mina Brewster. She is the health officer at St. Mary's County Health Department. So you can see the diversity here. Additionally, we have other members of the commission with population health experience in data and IT, funding, health equity. So I think it was really well thought out with regard to, the composition. And then, another reason being the legislation allows us to have work groups and members of the public to assist. Now, one thing I would mention is this commission came with zero funding, really. Zero funding. I would still take it as a win. for public health. A lot of our efforts here are guided by the work that have been done by other states, right? So you have other states like Indiana, they've done their work. We have Kentucky. We have a number of states, which I'll talk about in a minute. But the key takeaway is it's the successes of those states that have allowed us to have a template for the work that we're doing now. As I mentioned, those challenges persist, especially with, kickstarting a lot of our efforts. But again, the big work ahead of us is we have to conduct assessments of, foundational public health capabilities, and then make recommendations for improvements. Still on this slide here, I just want to talk about the strengths, because, we can't talk about, weaknesses alone. We need to talk about strengths that we've had as a commission so far. I've talked about the diversity being one of our strengths. Another strength here is we have a rich group here. We have health officers represented from all the local departments in Maryland, as part of either as part of the, the commission members or work group members. Additionally, we have the support of the CDC Foundation, right? Luckily, we're able to brainstorm again with a non-funded commission. We're able to brainstorm, just thinking outside the box. So we're able to have it such that we have an agreement, an MOU between the CDC Foundation and Maryland Association of County Health Officers. And this agreement would allow CDC to be able to help us to raise funding, right? A lot of the funding will be used to hire work group coordinators that will help steer the various work groups. Now, I wanted to mention that, these technical experts are not going to replace, they're not replacing the work of the commission members or members of the public. Like I said, we have over 100 members here. They're just there to provide that technical support. And if you look at the model, for example, Indiana, the model Indiana used, Indiana had they had a lot of leverage to begin with, right? They had a report that was already, before their commission started, they had a statewide assessment that was, that was done, that they were working with, and the report was put out by Fairbanks School of Public Health. Additionally, Indiana had, they had funding, right, from Fairbanks Foundation, and they also had some funding support from the state. So by the time their commission was established, they already had most of the data. For us now, the huge, task ahead of us, with our assessments, we need to look at specific things in the legislation, right? We're going to be really assessing through the work groups, right? Specific areas, and then, like I said, to make the recommendations. A lot of this, we're using the public health model right now to guide, our work. Another limitation that we had is, again, without this, support that we, that we lack, we're not able to really have that full-time, support. Like I said, the CDC Foundation is helping to raise the funding, but that is coming, slowly but surely. We're gaining momentum gradually. But right now, a lot of the commission members and members of the public they're donating their time, really, and we're all committed to this critical work. A lot of us are full-time jobs, right? So we're just really putting in our best, foot forward to get this work done. We've been able to leverage the support from state academic institutions, right? We're able to leverage support from the different universities that a lot of us have affiliations with. Morgan State University. So we have interns from Morgan State School of Public Health, Doctor of Public Health interns. We have Master of Public Health interns. We have interns from Johns Hopkins. We have one intern from Johns Hopkins. We have other interns from Coppin State University and University of Maryland School of Public Health. So those are some of the things that we've been able to do, to mitigate some of these challenges. Let me see, challenges. I think, those are some of the, the challenges and the strengths that I can touch on. Right. So next slide here is looking at how our objectives as the commission ties into the Alliance's objective, right? As you can see here, the Alliances, their work is really centered around advancing public health, public health and equity, right? To prevent disease, to promote health and well-being. And a lot of this efforts also mirrors APHA, which is the bigger umbrella, some of their objectives as well. Especially the efforts of the Alliance are centered around equity, preparedness and resilience, community and multi-sectoral partnership. Now at Maryland Commission on Public Health, as I've mentioned, the assessment. So now I'm sure you're wondering, what are the assessments, right? You hear assessment recommendations, right? What are, our assessments are really looking at surveillance, right? Assessment on community partnership development, assessment around equity, around organizational competencies, around policy development, accountability, performance management, emergency preparedness and response, and communications. And you can see here, you heard the word equity again. These are some of the ways it ties into APH's Alliance's efforts. And of course, part of our assessment requires that we explain the impact of the foundational public health capabilities on the state's ability to address the foundational public health areas specific to communicable disease control. How are, based on our assessments, how is, communication disease control, how is it in local departments and MDH? How it's chronic disease and injury prevention, how it's public health, maternal, child health, family health, access to and linkage to clinical care, behavioral health. So these are core assessments that we must look at. And we must make recommendations for reform through the various work groups. And also, so again, when you look at the, the various states that have done this work, it does provide us support. The commission members, it does provide us a template rather, but then you can't really compare the resources that we have versus the resources that they had. There were some other states, I think the next slide will talk, that have done similar work. Some states did their work through formal legislative actions, and some states just took the initiative, their public health system just took the initiatives to do the assessment. So, but at the end of the day, it's for the common good. That's the main thing, right? States are beginning to move towards this direction. And we're just so glad that Maryland is also taking the lead on this. In addition to assessment, I just wanted to make sure that, that I point out that we are also, the commission is also going to be required to do public outreach, right? Going to be required to, definitely take, people can email us questions. We'll put all of that into consideration when we are, when we're submitting our final report. And we have an opportunity to provide responses to the public. So right now, we are in the phase of just gathering data tools that we can use. We're in the phase of reaching out to partners, to local departments and MDH to see what data exists around the things we're supposed to do. Now we recognize that we might not have all the data that we need. So this is where we might have to develop, tools, data collection tools, quantitative, qualitative, and, conduct those interviews so that we can have just rich assessments for recommendation. So next slide here. So how are US states transforming their, so this was what I wanted to just highlight here. As you can see on the slide here, these are some of the states that have taken the bold step in modernizing their public health system. You have Washington. Washington did a baseline assessment in 2018, and they assessed the current capacity of their local and state health systems to provide foundational services. The assessment actually identified major deficiencies and calculated the need for about millions in additional public health funding. And that effort led to investment. They were able to secure funding through legislative actions that followed their assessment. So again, you see how this really translates into improvements in the public health system. Similarly, Ohio worked to identify deficiencies in the state's foundational services and determined the level of support that will be needed to close the gaps. Kentucky, they launched a bipartisan public health transformational program that provides funding to local departments to support the foundational public health services. So, in Kentucky, the health departments conduct regular assessments to evaluate and address their community health needs. So that has led to an ongoing effort. Imagine just, that's collaboration, right, between health departments, and seeing that effort as critical and continuing in that path. I think it's what is needed. Finally, I've talked about Indiana. I've talked about the successes that they have, and I just wanted to point out that Indiana, because they had their commission sunset, they are now in the implementation phase. In fact, their efforts, which very similar to the Public Health Commission's work in assessment and recommendations, they had six areas that they looked at. Ours, we had five through 5 work groups. They had 6. But I wanted to point out that they had so much success that they were able to have 1,500% funding increase. Again, we're so fortunate to have Dr. Judy Monroe, who was one of the commissioners during this work, and now she's overseeing the work of the CDC Foundation. And as I've mentioned, CDC Foundation is a key stakeholder in helping us, through that partnership we made, in helping us to raise funds for this commission's work. So again, Indiana's work, it's moving to the implementation phase, and I mean, just incredible work. And through that effort, the state has committed significant amount of funding, right, after the commission sunset. I'm talking about millions of dollars that is going to come out of that, and we'll see. Hopefully, there is an impact report to see how implementing those recommendations will transform Indiana's public health system. But we're very hopeful because, again, the states that have done it in the past have had positive things to report. While we're talking about this, some people may look at the stats in Maryland and say, why? Maryland seems to be doing fine compared to other states, and I think it's good to note that while, currently, Maryland ranks number 4 in healthcare, and in public health ranks number 10 among other US states. The metrics that were used for this assessment, and this assessment was the most recent assessment done by US News and World Report. It looks at mortality rates, suicide rates, smoking rates, mental health, infant mortality rate, adult obesity rate. We have to recognize that in public health, we don't work in silos. As I've mentioned, we have all these work groups that the commission is, is tasked to conduct its work through them, right? The public health system is really, it's politicized, and a lot of the politics, unfortunately, has led to where we are right now. Coupled with the chronic underfunding that is going on, a lot of just not having the capacity that is needed. There are lots of assessment that you see out there. And this is across board. It's not just a Maryland issue. So yes, Maryland ranked, number 10, right, for public health and 4 for health. But we have to recognize that despite the rankings, the state's public health facilities have grappled with and continue to grapple with existing realities in governance, in workforce, in several areas. I mean, people are, underpaid. People report low salaries compared to their counterparts that work in medicine, right, or in other sectors. We continue to deal with recruitment and hiring challenges, limited funding, and a lot of these issues have existed even before the COVID-19 pandemic. So, without going into too much of this, it's just important that we don't get carried away by the data, and we just need to understand that there are existing challenges in public health. And I think that concludes my slide. Thank you so much.
Thanks so much. That was
Yeah.
great.
Thank you. Exit it and stop
And if we
sharing.
can stop sharing, that's great. So I will now turn it to Katie Greene, and while she gets her slides going, Katie's a director for public health at the National Academy for State Health Policy, where she works on projects related to substance abuse and public health, including public health modernization and immunization. Before joining NASHP in April 2022, Katie worked as an assistant research director at the Duke Margolis Center for Public Health Policy and a program director for the National Governors Association, where she supported governors in a public health response to COVID-19 pandemic and co-led a joint health and public safety opioid response team. Previously, she served as senior policy advisor and associate director of the Office of Intergovernmental and Public Liaison at the White House Office of National Drug Control Policy and deputy director of the Federal Relations for Arizona Governor Janet Napolitano. She holds an MPP from Princeton School of Public and International Affairs and a BA from Duke University. Thanks so much, Katie, and I'll turn it to you.
Great. Thanks so much, Angie. And you can see my slides. Hear me okay? Okay, great. Technology barriers. So thanks again. I'm happy to be here. Really happy to actually jump off that last presentation on that point about silos and the health system and how we need to work together. So I'm here to talk about NASHP's work on public health modernization, which is really focused on strengthening collaboration with the health system. We've been fortunate to work with lots of folks on the line today. I see some familiar faces on the really hard and necessary work of building those foundational capabilities and sort of zeroing in today on that partnership capability and really sort of channeling public health 3.0 when it comes to public health as a convener and a catalyzer that can help work more efficiently and collaboratively, not only across government, but with partners like the health system and communities themselves. So just really quickly, for those of you that might not be familiar with NASHP, we are a nonpartisan nonprofit organization that supports state leaders in both the legislative and executive branches on state health policy with the goal of improving health and well-being of people across every state. When it comes to public health modernization, I usually start with a little bit of background on how we get here, and I can probably skip the public health 101 for this group. Other than to say the siloed systems of public health focused on upstream prevention and population-based interventions and the healthcare system that's been more focused on provision of individual clinical services really has its historical roots. But there have been several more recent trends that have really impacted the way that we think about delivery of upstream prevention and community investments and who should be doing it. So obviously there's been sort of just the perennial underinvestment in public health. And although public health very much does still play a safety net role in delivering services in many communities, there's been an overall trend away from direct delivery of those services. Secondly, thanks to many of the achievements in public health in the previous slide, thank you, vaccines. Chronic disease has really overtaken infectious disease as a primary driver of morbidity and mortality. And then a little bit more to the point of what we're talking about today, the health system shift towards value-based and population-based payments, buoyed by an increased understanding of the impact of social determinants of health and health-related social needs has really incentivized the health system to get more involved in communities and upstream prevention. And then lastly, this could be a presentation in of itself. We learned many lessons during COVID-19, both good and bad. Among them is how badly things can go when we don't have the right data and communication to make decisions. And then also how well things can go when everyone's really enabled to do what they do best and is working together. So bringing it back to Public Health 3.0, we've been thinking a lot about what does it really take to make progress in those, kind of bucket two innovative clinical prevention strategies that can really more effectively reach into communities and deliver services more effectively to those that need it most. So our work has, over the last year or so, has really taken a couple different fronts. First, we had a year-long learning collaborative where we worked in depth with teams from Arkansas, Indiana, Michigan, and Rhode Island, really to advance state-specific goals around collaboration with community and other partners. That took us in a lot of different directions, from data systems to health equity zones to community partnerships. And then we also developed a toolkit aimed at state policymakers, specifically on specific approaches for strengthening collaboration with health system partners. And that was informed by lots of interviews with state leaders. We had a great state leaders work group, and also spoke with experts across public health. And we heard a couple things loud and clear. First, none of this works if public health doesn't work, and just reiterating the need for continued leadership, continued resources, and sustained investment. Two, communities need to be meaningfully engaged from the beginning to the end in both policy development and delivery of services. And this was a frequently raised and a cliche, but there is no one size fits all. And there really needs to be a menu of strategies that can adapt across different public health infrastructures, different healthcare ecosystems, and political environments. And there's already a lot going on. This work needs to be done in the context of building on existing strengths, weaknesses, priorities. Public health doesn't do its work in a vacuum. So how do you harness, for instance, momentum in Medicaid around health-related social needs, work on housing, work on the opioid crisis, to work more effectively on these issues that we know really affect population health? So what we developed was a relatively expansive toolkit, given the menu of options, instructions we got. But I think what it really boils down to is what state policy often boils down to, which is how are you harnessing people, data, and money? In particular, there's been a lot of momentum around just how do you bring communities into decision making? How do you build that infrastructure for addressing health-related social needs? And how do you strengthen the role of public health data plays in sharing and exchanging data with healthcare partners, with communities? And how can Medicaid and public health work better together when it comes to supporting targeted interventions and improving population health outcomes? So one of the things that we talked a lot in the toolkit is about collaboration with Medicaid. And when I think about why public health might want to work with Medicaid, I think to this story about a reporter interviewing a famous bank robber in the 30s. And he said, "Why do you rob banks?" And he says, "Well, that's where the money is." And that is indeed a reason for public health to partner, just given the budgetary impact and the leverage that Medicaid can have. But even more important, equally important, is using the combined power of public health and healthcare data. Being able to blend and braid funding and really strategically invest those resources and efforts where they're needed most. So we have lots of great examples in the toolkit where Medicaid initiatives are supporting priorities identified in state health improvement plans, where immunization and Medicaid data is being used to identify disparities and target initiatives. I know Maryland has done some really fantastic work on this. And states using the power of MCO contracting to make community level investments and initiatives. So I imagine my time is winding down, but I did just want to highlight a few bright spots where this coordination and this alignment of people, money, data is really happening in interesting ways across states. First, I want to highlight just some areas where community-driven collective action models are happening. This looks incredibly different in different places. I've highlighted a couple examples here, including accountable communities for health, health equity zones, and a locally driven model in San Diego. But some really fantastic examples of place-based policymaking and sort of collective action models where states are playing a key role in empowering communities to address their unique challenges. Again, looks different, but state may play important roles in supporting a backbone entity, convening stakeholders, blending and braiding funding, or providing technical assistance in some cases. In terms of public and private partnerships, Virginia has a really excellent example of a partnership between the Department of Health, the hospital and healthcare associations, and providers, local public health, communities, lots of cool things going on in terms of aligning efforts and coalitions around common data and priorities identified within community health improvement plans. And then I know I'm just scratching the surface of everything that's happening in Medicaid, but another example of kind of where this is all coming together is Oregon's SHARE initiative. In this example, Oregon's coordinated care organizations, which function kind of like MCOs, really have to invest a portion of their profits in addressing of their net income and social determinants of health and equity services at the community level. This spending is aligned with not only the Oregon Health Authority's identified priorities within their state plan and focus on housing, but also has to align with community needs identified in their community health needs assessments and with the input of a community advisory council. So some really interesting examples of that creating that feedback loop and making sure to think about how to align funding and data towards community needs. So I know I went really quickly through all that and just kind of zeroed in a little bit on the community piece, but lots more there. I'm happy to share the link to the toolkit in the chat once I stop sharing my screen. But again, thanks for letting me talk about the toolkit and some of the work that we're doing. And I'm happy to answer any questions.
Thanks so much, Katie. I learned a lot very quickly. And I told the group we'll share slides later. And if you want to share links in the chat, that's great too. But we'll look forward to the discussion after Rya. So let me now introduce somebody who hopefully you all know, Rya Griffis, who's a project manager for the Alliance. She manages work including a Robert Wood Johnson Foundation funded project looking at public health authority. Rya has a background in health literacy and communications, healthcare, and social justice organizing. She got her master's in public health and health equity from the School of Health Policy and Management at the University of Maryland and studied for undergrad at the University of Colorado. And I will turn it to Rya.
Sorry, the mute kept running away from me. I love when that happens. Alrighty. Thanks for having me. So excited to take a moment to follow up on those really comprehensive discussions that we've already had today. Thank you, Katie and Dr. Olateju, for your insightful comments and insights. Both of you really gave us a strong vision for what we can do to improve the public health system. So it's very inspiring, but also a really comprehensive landscape to some of the challenges that public health is facing. So thanks again, and really happy to follow that. I wanted to take a moment to talk about a concept that some of you all are probably familiar with. Most of you all are probably familiar with to some extent. We saw that public health came under attack when COVID began, and those anti-public health sentiments have persisted. So for the next few moments, I wanted to discuss an imminent threat to public health in the form of policy and law. What I'll share today is a brief snippet of the amazing work of the Act for Public Health team and our amazing APHA state public health associations or state affiliates and our other partners. So will focus mostly on legislation, but it's important to note that these anti-public health sentiments take many forms. Just wanted to spend a moment to ground the conversation and touch on the Alliance team and APHA's roles in the space beyond obviously the comprehensive work that our government affairs and policy teams do. Our team is focused on the and currently funded by Robert Wood Johnson Foundation to mobilize our audiences to advocate for the protection of public health. We're doing so through funding state advocates, working with partners, providing support to advocates and affiliates, hosting trainings, and tracking legislative priorities in the states. The data we'll share today is from APHA state affiliates, as I mentioned, as well as the majority of the litigation and legislation tracking from Act for Public Health. So we definitely recommend that you check out the Act for Public Health website if you have questions or want to learn more about the trends that they're tracking. So what is public health authority? Public health authorities are legal authorities that vary by jurisdiction. They constitute a government's body, usually health or public health department or agency, ability to protect and improve public health by using tools such as community engagement, data collection, scientific research, laws and regulation, enforcement, and sharing information and guidance with those who need it most. As stated eloquently by the Network for Public Health Law and their innovative law and policies report, quote, public health departments require a full range of legal tools to fulfill their duty to protect public health so that individuals and communities can flourish. At the same time, though, the exercise of governmental public health authority must be accountable in ways that are both inclusive and supportive of the priorities and needs of disenfranchised communities that respect necessary checks and balances on that power, end quote. Awesome. So I'll just touch briefly on this because this has already been covered extensively, but how do we practice good public health authority? In order to have an equitable, robust, resilient public health system, public health agencies need to be equipped with the legal authorities to protect the public's health. Many states are working towards these ends, as Dr. Olateju and Katie have already talked about, and have made huge strides to cement public health's vital role in their states. Wanted to touch briefly on Vermont. They recently launched a bipartisan caucus of state legislators who care about public health and who are motivated to protect public health and public health authorities through legislation. Dr. Olateju has already gone in depth about the commission in Maryland and in Indiana, but we include them here to highlight the important work towards those ends. All of the examples, the state public health associations, in all of these examples, state public health associations or APHA affiliates have played major roles. And so did folks here on the calls today and in this alliance space with us. There are many more stories in all the states all over the US, as Dr. Olateju shared with us, including, yes, those states that have also seen attacks on public health authority and have what we might consider a more negative landscape to public health in their states. So the hope is there, and it's definitely possible to achieve these goals in any state in the United States. While there are many positive ways that states and advocates are positioning public health authority and building a robust and resilient public health system in their states, just wanted to take a moment also to touch on these anti-public health sentiments that are seeking to limit public health authority through legislation and litigation. First, I'll talk about legislation really quick. As a result of the COVID pandemic, states have rolled back public health authority. Unfortunately, even in the current legislative session, we're still seeing those same legislative tactics. Those tactics that, for instance, seek to limit what public health can do, such as limiting public health practices in a public health emergency. Examples of that include Iowa House File 2097, Kansas Senate Bill 391, Utah House Bill 405. And there's other bills that impose barriers to vaccination. We've seen that a lot, unfortunately, in recent legislative sessions, including examples like Minnesota House File 704, Iowa House File 2055, and many others that seek to hamstring public health agencies' ability to keep communities safe and healthy from epidemics. The good news is that the trend on the left that you'll see here on the screen shows that the majority of these bills did not become law, thanks to the tireless efforts of advocates in their states. I want to take a moment to share a small snapshot of the work that the team at the Public Health Law Watch and the Center for Public Health Law Research are doing on litigation or lawsuits that seek to limit public health authorities. Beyond legislation, public health authorities are challenged in court through lawsuits. Similarly to legislative trends, 2020 saw many lawsuits that sought to limit public health authorities, but those lawsuits continue to pose an ongoing threat to public health authority. Even just the threat of being sued for doing their jobs is something that hampers public health entities. The examples that I've highlighted today really focus on disease prevention, but of course, when public health authorities roll back, this affects the entire landscape of public health practice. While the challenges that anti-public health legislation and litigation pose to public health authority are certainly scary, there's a lot that you can do to advocate for the protection of public health at every level of government. Fundamentally, all public health professionals have the responsibility to share the importance of public health with their communities and decision makers. Sorry, I'm just seeing John's comment in the chat and I cannot remember what I was saying in that context, but I will definitely address that. And thanks, Sarah, for talking about that in the chat too. Awesome. There are many ways that you can advocate for public health, and getting tapped into the work that advocates are doing all over the country. Here are just a few ways, including advocating with Speak for Public Health initiative, tapping into the resources of Act for Public Health to learn more, getting involved in state policy advocacy and using our resource toolkit, which is QR coded here on the slide, to equip yourself or your networks to advocate to protect public health. I'll leave you with some reminders that we take into our advocacy work. In any advocacy that we do, it's vital to center the experiences of folks who are disproportionately impacted by the policies you're advocating on. It's also vital that your advocacy is equitable and seeks to uplift the existing voices in the space. With that, I will turn it back over to Angie.
Thanks, Rya. So we have all kinds of questions I know that I could ask our speakers, but I want to let others have a chance too. So we'll open it up now for questions. And we can use these or not, but if people want to raise their hands, I will try to find you. Right now I'm having trouble seeing you, but while we get started, I will ask one question of the panelists, and Rya, maybe we can put the discussion questions in the chat so we can see people. But for the different panelists, you can answer it as you want. We are a cross-sectoral group interested in public health from many different perspectives. Are there ways that we can be helpful in supporting some of these efforts to advance state transformation and modernization? Thanks.
I can jump in. So I don't have an easy answer for this, but you know, I think we all work for organizations that are supporting public health in some way, shape, or form, and we all kind of have our part. And I think if I had one common thread of what I said, it was that this looks different wherever you are. So, but kind of building those bridges, continuing to advocate for public health, and bringing others into the mix. I think where some of those transformation efforts have been really successful, it's been because they've been able to make advocates of people that have not always traditionally been advocates. So I think continuing to be good ambassadors is very important.
Thank you.
Thank you, Katie. I'm just going to add, I think those were wonderful points. I just also want to say that we need to recognize the power that we have, you know, to build momentum, to advocate for change, right? For example, APHA has, you know, affiliates across different states. In Maryland, it's MDPHA, made, you know, of professionals, you know, from different fields, you know, with different backgrounds, different expertise, and they can all lend their voice to change, right? To advocate for change rather. So that's one way that we can help support and to support and nurture states and communities. And we all know that funding drives a lot of the work that we do in public health. So foundations, corporations can fund nonprofit organizations, can fund advocacy organizations, right, to do this work, right, so that it can continue in this work, because it can be a lot of work, right? They need the resources. They need to go out there to conferences. They need to present their work. They need to let people know what they're doing. For example, what we're doing now is what we should continue to do. This is one way to spread the word. We need to keep doing this so other states that have not started some of these efforts can see what people are doing and go from there and use those states as examples to transform their public health system. So again, funding support from various entities, and then just us recognizing our power, that the power that we have. I think it's one way. Yeah.
Great, thank you.
You're welcome.
So we had a good question in the chat from Pam, and she asked, with all of the great state work underway, are groups such as the Commission or Katie, some of the states you've seen working around evaluation? How will we try to measure success? And Rya or folks from Act for Public Health, I'll let you all answer that also for the Public Health Authority question. Anything on evaluation?
Sorry,
say-
I didn't realize I was muted. I'm sorry.
Oh, that's okay, sorry.
Okay, sure. So the bulk of the work that we're planning to do around evaluation is just really looking at what the legislation says, right? Our evaluations will be informed by the assessments. As I've mentioned, we have to look at this assessments, look at the foundational areas, look at the foundational capabilities, specified. But currently, what we're doing is we're trying to see the data that exists, right? We're working closely with local departments, trying to gather data, just see what's out there. But we are challenged in some areas because some of this data do not exist. So we have to create assessment tools. We have to. A lot of this information too will be obtained through public meetings. We're really looking forward to those public meetings. The legislation stipulates at least 3. Right now, we have plans to have at least 5. It could even be more. But I feel like a lot of our assessments really, they might have to be just primary work that we're doing right now. We might, yes, some data exists, but a lot of it we're gonna have to find out as we go along. And again, those will inform our recommendations. Yeah.
The only thing I'd have to add here, with the slight worry of getting over my skis, is that I think a lot of the public health transformation efforts are really built on accreditation and foundational areas and foundational capabilities, and a process that is really intended to be able to assess capabilities on a set of core services. So I think that provides a lot of foundation for understanding and evaluating, at least your public health systems. Another piece that I understand to be a big part of the Indiana experience is just listening to people and getting that community input about what matters to them. So that's sort of the less quantifiable piece, but I think important as well to be making sure you're getting that input and feedback from partners in the community.
That's great. And I know just in terms of what we've been looking at, we've been trying to figure out where do we need to go next in the public health system, we realize finding out what some of those measures are for success, how will we tell if we're really seeing transformation and we're making a difference, are really important. I know Center for Public Health Law Research has done some of that work around public health authority, so can send you a link to some of that, but I think certainly a really important question. Knowing we're short on time though, I'm going to turn to one more that a couple people are interested in, which is whether someone could talk a little bit about navigating preemption to protect public health and getting beyond cooling effects. And I will turn it to Rya, and then if anybody else wants to jump in, please do.
Yeah, I'm definitely absolutely over my skis on this one, but I wanted to say, to define preemption quickly in layman's terms, I'm absolutely no preemption expert, but essentially preemption is a tool, a legislative tool that where there's many different types of preemption. But in this case, preemption is a tool that has often been used to limit public health authority, where it makes it so that a higher form of government limits what a lower form of government is able to do. There's a few different types of preemption in that, but we won't necessarily have to go into that. There are a number of groups that work explicitly on preemption, including Local Solutions Support Center and Voices for Healthy Kids. I definitely look to them as the public health partners that are working on public health and related topics in the preemption space. And I know that they've done some work on how to kind of flip that, because we've seen preemption used a lot for limiting public health authority, and how to flip that to, floor preemption, which really is, makes it so that we need a base level of kind of understanding of what public health is and how public health can contribute to and add to communities. And so there's many different ways that you can definitely do that. And I think this is a really good point, but I'll turn it over to the panelists also to add to this here, but also anybody who's a part of the meeting who has stuff to add there as well.
I think I see Sarah.
I know, I was writing this big chat, I think, and I think it's tied to preemption as well. But let me focus on preemption. I think something we try to talk about is that preemption is a tool that can have good outcomes or bad outcomes. And there needs to be a little bit more awareness about evaluating the effects of preemption, which gets us back to evaluation, right? In any given case, we're looking not only for health outcomes, right? Like we want to see change and we know that there's a longer trajectory. So we also want to see some process outcomes that matter to the people funding the work, the people supporting the work, so that we don't lose them just because we're not having 1 year returns, right, on our policy investments. And I think that is the balance of what we're moving forward. And Temple, the Center for Public Health Law Research, the CDC, all sorts of programs that are building in legal epi are trying to identify what is actually working so that we can get that data out in front of the policies we want to see scaled up and out in different places. And that's when we get into the well, how do we use the data by making sure we're not violating 14th Amendment? This is too in the weeds, but it's you got to be careful about how you use that data. So the more types of data we have, the more measures we have that show that it's doing what we want it to do, that it's improving the public's health. I saw Martha on the call, the better. So we're here for it. We're collecting it. Send us your ideas. Send us your measures.
Great. And I know we are at 3 o'clock. Thank you so much. So just want to thank our fabulous panelists. We will send all this information later, but these are places where we really want to know what you're hearing in your states. Please let us know whether we can help to support transformation or help to protect challenges that we're seeing. But thank you once again to our panelists. I know I learned a lot from you and look forward to sharing it with those who couldn't join the meeting today, and hope to see many of you next month for our next meeting in March. So everybody have a great month, and thank you so much.
Thank you.